that. Okay, I think we are ready. Anything going on? No? Okay, good. Well, Peter and Chris will be here, I'm sure they will, but I didn't dig into everything, so I really dug into more of what you guys are going to use, and we can kind of go over it as far as you want. Obviously, you're going to go through most of these approaches this year, but there's some that are somewhat antiquated that you're probably never going to use, and we can kind of go through that a little bit. But you know, doing an open rotator cuff repair at some level is somewhat historical, although it's like doing an open bank art, that understanding how to do the operation and how to do it correctly, there's some value in it. You may be in a situation where you need to be able to kind of do the operation. The biggest issues with, honestly, an open cuff repair is taking the deltoid down and then repairing it and getting it to heal. And that's been one of the biggest issues with kind of prior open standard cuff repairs, is that deltoid dehiscence was one of the biggest complications that patients had. And when that happens, it's a real disaster. And so it's not that difficult. It usually just means drilling holes into the acromion, passing stitches through the holes, and then making sure that you're incorporating the CA ligament into your reconstruction when you're actually doing your repair. But it's like one of those things where if no one shows you how to do it, sometimes it becomes nerve-wracking when you're you know, doing something. So that's something actually down in the lab at some point when we have a cadaver, like even next Tuesday. I'm happy when we're down there doing the total shoulder, that we can just do a anterior superior approach so that you guys can see that. The other thing is that when we do the total shoulder, what we can do is, and I think would be really helpful, is to do a tenotomy, and do a tenotomy in the fashion of how you would do a tenotomy at the anterior approach, like you'd be doing an open bank art repair. Because again, you guys don't really see that much, and I don't know if have you ever seen an open bank art? Okay. I don't know if you guys know.
One, but it was like iconic.
Yeah, so again, it's like one of these things where there's different ways to be able to manage the subscap. That's probably your biggest kind of concern when you're doing an open bank art. And there are definitely tricks with regards to how to make sure that you leave an appropriate level of stump on the lesser tuberosity to make sure that you develop the interval between capsule and subscap correctly, so that you can kind of do it efficiently and not destroy the subscapularis in the process of doing that. And so little things like that, and then how to repair it, do you know what I mean? And so we can even do that next Tuesday too in the lab when we're going through things. So like I said, I'm going to be, this is pretty open-ended in terms of what we'll do here. It's basically reviewing our classic approaches, and then I'm going to kind of avoid the anatomy, because I think we have another lecture with regards to just pure anatomy, and so I'm not going to really dig into that too much beyond the basics, and then try to kind of make this clinically relevant. So starting with deltopectoral approach. In general, you're going to be doing your deltopec in a beach chair position. You guys are all familiar with beach chair. Can you do this in a lateral decubus position? Totally, it's possible. It's a little bit harder to be able to do. The most common reason to do a deltopec in the lateral position is if most of the work that you're doing is in the back. And so say that you are going to be doing a posterior approach for whatever you're doing, and that there's a reason that you need to go back anteriorly, then yeah, then doing it in the lateral position. Times when I've done it, if I'm doing a shoulder fusion, and so if someone has a hardware that's still there, I do my fusions through posterior approach. So I'll do it, they'll be lateral when we'll do this, and so then I'll position them, or I'll start posteriorly, but then If they've got a plate from a prior reconstruction, then we'll go back anteriorly to be able to actually take the plate and screws out. So things like that. So it's things again tend to fall medially when you're doing that, but for whatever it's worth, it's possible. When you're, I'm not going to go through positioning, et cetera, but the bottom line is you want to make sure your shoulder is free, make sure that there's some support underneath the scapula, and make sure that, at least for myself, that there's some support so that the patient doesn't fall off the bed towards you. The incision, very standard and simple and easy. We go through this in the operating room when we're kind of marking out this incision. The 2 points that you need to know are the coracoid and the deltoid insertion. The deltoid inserts halfway down the humerus, and so when we're doing this, basically I have you guys identify the coracoid, and then we identify at the elbow, 50% down the elbow. The arm is here, and then if you take a point that's 50% or midway from the medial to lateral portions of the humerus, directly at the level of the center of the the deltoid insertion, and you take a point on the medial aspect of the coracoid, those are your 2 lines, makes a straight line. That's your deltopectoral incision. The reason why you're doing that is because we know the anterior head of the deltoid drapes over the coracoid, so you're trying to put your incision directly over the interval. Even despite that, the reality is that the other reason to do it is that what you're doing is you're continuously working medial. So every time that you make a deltopectoral incision, all your work is medial. You're never working laterally. So it doesn't make much sense to be able to actually expose more lateral soft tissues. Now that's different a little bit than where you may have trained. And so depending upon, there's different schools of thought. If you're Columbia School of Thought, if you're Mayo Clinic School of Thought, if you're Dr. Neer versus, Dr. Cofield versus Dr. Rockwood, all of those people have different opinions with regards to where the incision should be placed. And that has then somewhat infiltrated down to, second, third, and fourth generation surgeons. And so if the Mayo Clinic incision is actually this. It's a much bigger incision and it's much more lateral. So they expose a huge amount of deltoid in the process. And what they'll make the point, and I've talked to Quinn about this, is that their feeling is that by doing that, it's easier to retract the soft tissues more posteriorly by exposing more deltoid. It doesn't make a lot of sense to me that you don't necessarily need to expose the muscle to retract it, but at least that's what the thought is. But the thing what happens is that when you do that, you need to make a much longer incision. So your incision is like about a third of the length longer if you actually go much more laterally. So in general, place the incision a little bit more medially, and because you're going to work medially. So you dissect down, and when you guys will see when we're in the operating room, I'll have you kind of bovie through the soft tissue, and what I like to do is just totally skip the interval. So I don't even like to go there. So the whole idea is you work medial until you actually get muscle, the pectoralis. So you're avoiding the vein completely. You're not even going there. And then once you've gotten the muscle exposed, then you go proximally, and then you find this interval between pectoralis and deltoid. And that's where you'll then start working distally. You can take the vein either medially or laterally. Concept, as you guys know, laterally there's more trauma when you're placing your retractors there. The benefit is that all the perforators, or most of the perforators, come from lateral to medial, so you leave the perforators. If you take it medial, theoretically there's less trauma to the vein, but you have to then ligate all the perforators that are there. What you'll notice is that there are usually 2 or 3 perforators that still come from medial to lateral, even if you take your vein laterally, dependent upon the patient. So don't be surprised if you get some bleeding in that area. The next step is kind of how to get subdeltoid. So, and there's 2 different for me, there's 2 different approaches, and you'll see this when we actually are in the operating room when we're doing kind of cases. It's whether you're in the primary setting or your revision setting. So in the primary setting, you've identified your vein. You've then gone bluntly through your deltopectoral interval. I don't use a Metzen balm and spread, et cetera. It's a internervous plane, so the muscles should separate themselves without actually doing much dissection. And then the location of where to get subdeltoid is at the pectoralis insertion. You should be able to see it very easily, and that's a safe zone. Technically, your axillary nerve is going to be slightly superior to that. So at some level, if you're at right where the pectoralis inserts distally, and which is basically where the deltoid inserts, you know your axillary nerve is going to be just slightly proximal. And you'll slip underneath the deltoid at that point. There's usually a small plexus of veins there, so just be careful. So when you're going there, they're usually perforators that are coming from your circumflex vessels. So when your circumflex arterial vessels come around from back to front, there's a plexus of veins that come with it, and that's what's going to bleed. And so just be careful when you're actually down there to avoid them. Usually what I tell people is when you get your little window, only work proximal. So like pushing more distally down there at the distal end doesn't make any sense, and all you're going to do is tear or rip the venous branches when you're down there. And then work from proximal, from distal to proximal, sweeping up underneath the deltoid. If you struggle because of scar or whatnot, so a lot of times your scar tissue from prior either cuff repairs or surgical approaches, it's not going to be at that distal level between your pectoralis and like the lower border of the subscapularis. It's going to be at the level of the subscap and proximally. It's where all rotator cuff work is, etc. So when if you're struggling there, the idea is, or at least what I do, is you skip it, and so then you go back, you go to the other place where it's actually easy to get, which is more proximally. So once you've identified the anatomy proximally, you should be able to see your coracoid strap muscles. You should be able to see the CA ligament coming off of that. You want to peel your deltoid a little bit up off your CA ligament and your coracoid, so you can see this whole structure here. So once you get there, and you can't get here because of scar, the next step is you go directly underneath the CA ligament. So what I'll do is I'll take a scissor, curve mayo, whatever, and as long as you're underneath the CA ligament, you know that you're underneath the acromion. So then you've got two places. You've got underneath the acromion, and then you've got more distal, and then you just got to work to connect the two. Especially in cases when you're trying to preserve the rotator cuff, like in the case of an infected total shoulder where you don't want to violate it, where you're not going to be doing a reverse shoulder replacement, it's important to be able to do that. So once you've got subdeltoid, then the next issue is getting between your strap muscles and subscapularis. And so that in a primary setting is really easy. Again, when you guys are in the OR with me, what you'll see is that usually I'll take a millimeter or two of the CA ligament. I don't take the whole thing, but by simply doing that, what happens is it releases the interval of this kind of area where this false ligament is between the CA ligament and what is the extension of the clavipectoral fascia more distally. And simply by doing that, you can actually duck in underneath the straps and subscapularis, and it's an easy way to get access there. Don't go here. Now you can go here, and we talked about this the other day in the operating room. So this is for a primary setting, but for a revision setting, usually the place that's scarred is right here. So it's right around the axillary nerve. So the place not to start is actually either up here or directly here. So usually the place where I will have you start is down here, lower at the muscular portion, because that tissue is usually preserved. So working more distal to proximal at the muscular portion between the straps and the subscapularis, you'll find an easy interval there. Then what I'll do is once you get here, then you can come back up top here and work here, and the last place to work is right over the axillary nerve. And again, spreading carefully, gently, kind of using your finger, etc. So going where the place where your highest likelihood to have an injury last is my suggestion. So then you've developed your interval between your strap muscles and subscapularis, and then you can do your deep approaches. So again, deltopectoral approach, like you can see your fat stripe there directly in the middle. Medially, you see pectoralis. Laterally, you see deltoid. This is more proximally that interval between the pec and the deltoid, where I was saying that you want to go and find a blunt interval between the two, and then distally work between your deltoid and pec. Here are your perforators. You can see that medially there's much fewer than laterally. So again, you want to be able to take the vein. I usually will take it laterally, but again, it's surgeon preference. Once you've developed that interval, again, working distally here, getting underneath the deltoid, and then working proximally. If you struggle in this area, identify the area between the coracoid ciliate ligament and the strap muscles, work underneath the acromion, and then work back and forth in this area. Different people will do different things. I use a curved Mayo scissor, and the reason why I use a curved Mayo is that the Mayo is, on the other ends of the Mayo, is blunt, meaning that the edges of the scissor are blunted. A lot of people, including Chris, where Chris trained with the surgeons there, they use a Cobb elevator. And so the Cobb is not my preference. And the reason is because a Cobb is sharp, and there's obviously neurovascular structures there. There's a lot of good surgeons that use a Cobb. I'm not saying that it's wrong. It's just that my preference is to use something that's more blunted and maybe has less chance of injury with that. Again, at this point, you can see here what we're doing is developing this interval between the strap muscles and subscapularis, and then you've got your front of your subscapularis for deep exposure. How you take down the subscapularis, again, that's kind of, we'll get into that more with total shoulder. So I'm not going to go really into deep approaches, because whether you do an osteotomy or a tenotomy or a peel, we're going to talk about that when we actually start talking about doing total shoulder replacements. So it's probably not relevant here. But clearly there's different options, and even next week we can go over how to do a tenotomy for a Bankart. Important is the relationship of the neurovascular structures. So obviously, just inferior to your subscapularis, from an interval standpoint, is going to be your latissimus. And so if you're on your humerus, subscapularis is going to be here, your latissimus is going to be here, your teres major is going to be here, and your pectoralis is going to be here with your biceps tendon here. So the integral of the lower border of your subscapularis and your latissimus, that's where your axillary nerve is going to actually sit and then exit posteriorly into your quadrilateral space. You can identify that. Obviously, the lower border of the subscapularis is identified by the three sisters. Very easy, and it's a useful landmark, again, when you're going to be doing your tenotomy, that you exit your tenotomy just superior, a millimeter or two above it. As the axillary nerve travels posteriorly through the quadrilateral space, its relationship to the glenoid is important. The closest position that the axillary nerve is to the glenoid is about the 530 position anteriorly. So this is useful somewhat arthroscopically when you're doing arthroscopic instability repairs, etc. The more abduction, abduction that the arm is placed, the closer that nerve travels towards the actual glenoid. So there's some value in having potentially lower degrees of abduction, and especially when you're doing instability repairs, really high degrees of abduction brings that nerve closer to the glenoid and potentially puts it at risk. That being said, if you look at the minimal distance at that zone, it's probably you're talking a centimeter. And then as it goes more posteriorly, it exits posteriorly and laterally, so it's getting further away from the glenoid. So this is important both arthroscopically when you're doing a Bankart repair, but obviously open when you're doing open surgery. When you're exposing the glenoid, working at the inferior aspect of the glenoid, you have to understand the relationship of the nerve to the glenoid. So the only thing that can kind of fool you is the branching of the axillary nerve. So there's going to be a branch, the posterior branch of the axillary nerve has variable takeoff. And so in general, a majority of the time, it's going to exit, or it's going to divide posterior to the glenoid. So meaning that it's going to track through anteriorly, going through the quadrilateral space. You're looking at the face of the glenoid here, if you're doing a total shoulder, and your division is going to occur here. It's not going to occur here. That being said, that can occur, and I've seen it, and I've been in the OR with it, and it's a little bit disconcerting when you actually do that, because if you're going to expose the nerve, and what you're feeling for is a single structure, and if the nerve has divided here, then you've felt a single structure and you're like, okay, I'm safe, but then there's actually two structures, and that can be a problem because then you can transect it. So it's pretty uncommon. Honestly, as you guys know, I'll dissect out the nerve in every total shoulder. It's probably run across it half a dozen times. So not very often, but it's there, and it can be a little bit unnerving because at some level you think that you're safe, and then all of a sudden you realize that you're probably not safe because there's something else that's there that's important. So just be aware of it. How to kind of avoid injuring it is making sure that when you dissect and you feel the nerve, that before you start releasing tissue, that you're all the way to bone. It's pretty easy. So what you don't want to do is dissect inferiorly and you're working lateral to medial and you're like, okay, I got a structure, I'm cool, everything's all right, I protect it, and then you start working medially towards the glenoid. There could be another structure that's more medial than where you are. So the key is going all the way to bone, making sure that you feel bone with either your instrument or whatnot, your finger, and then whatever's there underneath it, then it's safe to actually to bovie. So here's kind of just what I was saying. It's actually it's a little bit more posterior than the 6 o'clock. So at some level, you're not going to actually really get that as long as you actually the branches, because it's usually more posterior than it's as it's exiting. Then once it comes around the back, then the relationship is, okay, how is it in relationship to the lateral board of the acromion? And that is important when you're doing a lateral approach, obviously, or a muscle splitting approach. I don't do it a lot. I know you guys probably train with a lot of trauma surgeons that do like to do it. I'm not a big fan of it personally because of going back and having the nerve scarred to the plate, et cetera, but it's definitely an option, and it does give you better exposure to the tuberosity to repair it. Chris, I think you've done it before, haven't you? Yeah.
Not since I've been.
Okay.
The same reason. I mean, if you're doing like an ankle repair or something, it's not fine, but if you're putting like a plate on.
Yeah, it basically just drapes over.
Skeletonized, like sitting around.
Yeah. And Peter, I don't think you do that at all.
The only time I've done that is for an isolated tuberosity fracture. It's too big a piece to be addressed arthroscopically, and that's just a really rare nerve.
Sure, I agree. The key with this is that the closest, again, to the acromion is now more posterior. So it's opposite of your glenoid. So as it's coming from front to back in the inferior aspect of the glenoid, it's closest anteriorly and it's furthest away posteriorly. But then as it's coming around from back to front in relationship to the acromion, it's closest posteriorly, and then it's further away from the acromion laterally. Usually, if you're kind of in this 4.5 to 5 centimeter, as you can see here, zone, you're going to be safe. My portals, I use 3 fingers, as you guys, or 2 fingers, as you guys know. 2 of my fingers is 3.5 centimeters, so I've measured it. I know what my 2 fingers are together, so that's why I use my 2 fingers in the operating room for my lateral portals for my arthroscopy, so I know every time, hopefully, that my portal sites are going to be above my axillary nerve. Deltoid split. So usually the typical location of the deltoid split is between the anterior and middle heads of the deltoid. This gets back to kind of what the historical approach to doing an open cuff repair. When you do an open cuff repair, if you want to think of it, that the acromion comes like this, your AC joint is here, your CA ligament's coming here, coracoid is here, acromion's coming back, the visor portal, etc. Your anterior head of your deltoid takes origin from the portion of your clavicle here and extends over to the acromion, and it exits about right here. That's where the interval between anterior and middle heads is. And then your middle head goes all the way back and then extends about to the posterior lateral corner of the acromion. So the location of where you want to try to make your deltoid split is between your anterior and lateral heads. Oftentimes, you can see on this image, there can be a little kind of raphe between the two, but I'll be honest, it can be hard. You can use your bovie to be able to activate the muscle to see if it activates a little differently. But the key, most people, what they'll do is they'll bring that up to the acromion and not take anything down. And that's your classic approach for many open rotator cuff repair. So historically, many open cuff repairs, none of the deltoid was actually taken down. If you need more exposure, that's when you actually will bring this up. So the incision that you make for this operation is the incision is in Langer's lines here. It's just about kind of a couple millimeters medial to the acromion, to the lateral board of the acromion. And then what you'll do is you'll dissect that out to make more of a circular kind of exposure. And then you've exposed this. Then what you'll do is you take your bovie and you'll bovie down kind of off the anterior aspect of the acromion. So this is a classic, if you do a superior approach for a total shoulder, this is how you do a superior approach for a total shoulder. And if you do that, then oftentimes what you'll do is you'll actually even extend this all the way out to the clavicle. The reason why, because the fascia around the clavicle, it's actually pretty dense and into the, obviously the superior aspect of the capsule, and passing stitches into that to be able to repair the deltoid is actually fairly beefy. So once you've taken that down, the CA ligament comes down with the muscle as a big flap. And so then with a repair, what you need to do is you put a drill hole in the acromion here, a drill hole in the acromion here. Then you'll pass high strength suture here in that hole underneath the acromion and then back out. So then it's basically in a mattress fashion. And then you'll take this one limb of this stitch, you'll pass it through. The same stitch, oftentimes what I'll do is I'll pass it as a Mason Allen stitch. The other limb, I'll place it as a Mason Allen stitch, and the other stitch, one limb of it, and the other limb of that stitch, I'll place as a simple. So it's basically a Mason Allen and a simple for each of the stitches. And when you're passing these, you're basically passing it not just through the deltoid, but incorporating it into the CA ligament, and you tie it. And then you can do some, interrupted figure of eights. But that's how you take it down, and that's how you repair it. And if you do that, the likelihood of it healing is actually pretty high. The only part where you can get screwed is if you have an infection. So that's the problem. So that if you open cuff repairs are much higher risk, cuff repair risk of infection, you're talking 1/100 of a percentage point. Open cuff repair, historically, it's somewhere 0.5 percentage point is where you're looking at a risk for infection. If you have an infection with someone that you've taken their deltoid down, it becomes a very complicated problem. Deltoid split, you can see the relationship to the nerve, 4.5 to 5 centimeters. Then more anteriorly, it's going to be kind of more closer to 6.5. Here's a case. This is not my case. You can see the exposure through a lateral approach. This is coming from Serena, actually. He gave me this case. And this is him packing bone graft. And this is kind of the relationship. And so you can see the suture reconstruction of the plate, but then obviously the axillary nerve is basically draped right over the plate. So this kind of makes me nauseous a little bit looking at this, but it definitely works. And I think that, if patients were having complete axillary nerve palsies every time that this was occurring, people wouldn't do it. Do you know what I mean? So it's not like it can't be done safely. It's just not necessarily my preference. So that's both anterior or deltoid pectoral and lateral or deltoid split approaches. The other major approach that you're going to use is your posterior approach. And this is much less familiar, obviously, for most surgeons because we just don't do it very frequently. Indications, glenoid fractures, posterior bone grafting, open soft tissue posterior instability. Those are your primary reasons why you're going to be doing this approach. So glenoid, scapular neck fractures, and open bone grafting procedures. And there's definitely some tricks of doing this. It's unusual anatomy, and so you just have to kind of be cognizant of it. The first thing is your skin incision. So the skin incision for a posterior approach, there's different ways to address the skin incision. But if you want to think of it, again, the front of the shoulder, front of the shoulder here, you've got your coracoid, you've got your deltopectoral incision. If we then take a look at it from the lateral side, what I just showed you from the lateral side is that the acromion's coming down here, your superior approach, you bring that superior approach just kind of medial to the acromion. Well, what that is that can be extended more anteriorly. So it extends into the deltopectoral approach. And that same superior approach can then be extended into the posterior approach. So theoretically, you should be able to make a single skin incision that's a posterior approach, superior approach, all the way down into a deltopectoral approach that's a single incision. And that's where you should probably be placing your incision. So from the back of the shoulder, looking at the back of the shoulder, that if the axillary fold is here, your typical superior approach, the incision is going to be something that's going to be something like this. And you can think of it theoretically as it coming back over the top of it. So you can use the landmark of your acromion, which is going to be here. You want that incision to be, you know, a couple centimeter or so medial to the lateral margin of your acromion. Very similar to where you're going to be putting your posterior portal with doing an arthroscopy. Think about where your posterior portal is going to go. Posterior portal, the ideal location of where it's going to enter into the joint is at the interval between teres minor and infraspinatus. So that's basically where you want to actually place your incision if you're going to be doing a posterior approach to the shoulder. And that's honestly with portal development, that's how they actually decided the locations of where to place portals, is that they put, if you go back and read with regards to how portals were developed, they made the portals in the locations of where the open incisions were. The musculature on the back of your shoulder is obviously the interval that you're going for is interval between infraspinatus and teres minor. You know, people will often say that there's a muscular fatty fold that's between the two. It's pretty variable to find that. So for me personally, it often takes, again, I'll use activation of the muscle to be able to actually see what muscle is contracting that isn't. Now, the upper and lower portions of the infraspinatus can also contract differentially, so you can't get fooled by that. The other is working, if you're lost, is to go further inferior. So to find the interval between teres major and teres minor. And that is actually fairly easy to actually find. And because if you work more medially from teres major and teres minor, that's the vessels are going to be there. So this triangular space is where your circumflex vessels are going to come through. And so at some level, granted, you don't want to violate those, but it's a way to reorient yourself if you are lost in the back of the shoulder. So you work both proximally and distally. Proximally, you're going to be able to find the spine of the scapula, so that's going to be easily. But the issue, so you're going to know what infraspinatus muscle is, but what you're trying to find is the difference between infraspinatus and teres minor. And so the way to do that, to me, is that you go distally and you find teres major, which is really easy to find. And then you've got an idea where infraspinatus is, you've got an idea where teres minor is, you can find, or teres major is, you can find the interval fairly easy between major and minor. And then you've got a pretty good idea where the difference is between what is activating is a teres minor versus infraspinatus. So once you've found that interval, then it's blunt dissection. And so it's blunt dissection going laterally. Oftentimes it's muscular all the way to the humerus, so there isn't a lot of like cauterization of tendon tissue. It's just usually blunt dissection down to capsule. Retractor placement and arm position, you know, the key you can see with this up here, they've got this retractor here. You got to be careful of that retractor because that's exactly where the suprascapular nerve is. So I don't use Homans. I use right angle retractors when I'm doing this, especially with the superior retraction. Inferiorly, you're pretty safe. You're not going to hurt anything. You're not going to hurt the axillary nerve. The axillary nerve and the radial nerve are lateral and inferior in this approach. So they are like totally safe and out of the way. Your biggest risk is suprascapular nerve. And then as you're working laterally, the key is, okay, where am I? And that can be confusing also because it's different than looking at the front of the shoulder, that you're going to see this sheet of tissue that is, you're going to be like, I think this is capsule and I think this is humerus, but I have no idea where the glenoid is and where do I make my entry site into the glenoid? And so the little trick with that is you use a spinal needle. And so what I'll do is I'll take a spinal needle and I'll work the spinal needle from the scapula, moving laterally to the point where then you enter into the joint, and that's where you know you can make your arthrotomy. There's really no way, whether you're going to do a posterior glenoid bone graft, whether you're going to do a fracture fixation, you need to make an arthrotomy in the back of the shoulder. You can't just fix it blindly if you're going to be doing any type of glenohumeral work. or at least I don't recommend it. You could theoretically kind of key in a fracture without looking at the articular surface, but if it's an intra-articular fracture, I would highly not recommend that, because also you're going to place fixation, and you want to make sure that your fixation is not in the joint. The other thing is the version. So coming from the back, it is usually what you will see is that you can't see across the joint. That's one of the hardest things in the posterior approach, is that getting your view across the joint is not like when you're doing a latarjet. When you're looking, you can look all the way from the front to the back. That exposure is not going to be there. So if you don't open the joint, you're going to be confused with regards to the angulation of your instrumentation going from back to front. And even when you do open the joint, it can be confusing. So oftentimes what I'll do is I'll open the joint and I'll put like a freer directly across the joint, because that will give me some idea with regards to the version that I'm working with. How do you open it up? Usually I just go superior to inferior. So you find the interval between, just off the glenoid, and then just make an arthrotomy, and it's usually just lateral to your labrum. Scapula fractures. So the only other thing, so that's if you're doing intra-articular. If you're going to be fixing a neck fracture, obviously you don't necessarily need to be there. You need to know where the glenoid is, but obviously your work is more inferior medial. There's two different types of fixation. Obviously, for your glenoid neck fractures, you can, a lot of the historic, standard kind of way that people will fix them from a plate fixation is that they'll take a plate and they'll run it down the column just like this, because your fracture is something like this. The problem with doing this is that you're going to get an ascending branch of the vessel that's right here, which is coming from those vessels that are coming from back to front. It's always there. And you have to be aware that it's there when you're dissecting down the axillary board of the scapula. You just have to know that it's there, and you can cut it and coagulate it, and that's not a problem. It's just that if you don't, and you don't realize it, you can cut it, it can bleed, and then it will actually retract, and then it can become a big pain in the ass. And so one way to avoid having to dissect down in this area is, instead of using fixation that goes all the way down this the lateral board of the scapula, traditionally for me, what I'll do is I'll stack small plates like this. So you can stack usually like 2 or 3, 2-4 or 2-7 plates, and they can be 4-hole, 2-4, 2-7 plates. And if you guys have ever been in the OR doing these operations, the hardest part is getting the reduction. There's so much muscle around these that once you've actually achieved the reduction, it's fairly stable, so that the plates and screws aren't necessarily like taking something that's highly unstable. The muscular forces are what's actually holding this into place, and then you just got to keep it aligned. So 2 or 3 small stack plates. Biomechanically, we looked at the fixation is identical to if you use a standard posterolateral plate. And again, you don't have to do all the soft tissue stripping. Your window is the same window that you're going to have if you do a distal tibial allograft in the back of the shoulder. So intraoperatively, this is kind of what you're seeing. Oh, the last part, the deltoid. So before you get down to that window, your exposure, your deltoid, how do you kind of do that, or what's the deal with that? So when you make your incision, you're going to see this fascia in the back of the shoulder. And again, the key with defining this, the deltoid versus the posterior rotator cuff, is you got to work medially, because if you work medially, then what you'll be able to see and you'll be able to activate is the infraspinatus. And so what you don't want to do is get caught in here to think that that's where your interval is and where you need to get into the shoulder. So you need to define this posterior border of the deltoid. And the way to do that is you continuously work medial until you actually see the rotator cuff. The place where you need to be careful when you're actually then defining this interval is right here. So if you're going to start the interval between posterior fascia, deltoid, and infraspinatus, do it proximally. So do it in this location, because if you start here, that's where the axillary nerve is. And so there's going to be a cutaneous branch that comes out distally, and that's what this depiction is of this. But you can actually get into the motor branch that goes to the posterior head of the deltoid, and you don't want to do that. And so I would, if you're going to when you're defining this, I would recommend you start proximally at the interval between infraspinatus. Now, we've gotten a lot better with the back of the shoulder because of lower trap transfers. So right now, this is the area where we're really comfortable actually working right now, and we're used to this. So honestly, if you just extend your dissection a little bit more over here, you'll be able to find lower trap, which now we do a lot, and then you just you can work backwards back to the deltoid. So again, here you can see what the deltoid is above. This is rotator cuff muscle below. Deltoid's being retracted. You can use basically just like we do a brown deltoid retractor in the back, just as you do a brown deltoid retractor in the front. If you need to release some posterior head of the deltoid, it's totally fine. So if you want to do that, just bovie it right off the deltoid, off the spine of the acromion, and you will be able to get much better retraction. You just got to put drill holes through the acromion and then repair it back just like you would normally repair a structure back. So it's totally okay to take a little bit of that down. And then defining your interval here between your teres and your infraspinatus, retracting superiorly and inferiorly to getting down to the glenoid. The last kind of approach is your kind of classic Judet approach. So this is, again, instead of retracting this deltoid up and doing a split, that's actually taking the part of the deltoid down and your whole rotator cuff musculature and flipping it up the other way. So flipping it from medial to lateral. I would, again, not recommend this unless you absolutely have to, because it's fairly, it's fairly traumatic to the rotator cuff, and these people will definitely have weakness if you actually do this for a prolonged period of time. And so even though the x-rays look pretty, they have, at least in my experience, fairly significant external rotation weakness when you actually do this. The last slide here, or last slide or two, is, okay, how do you extend the deltopectoral approach? So extension of it from the front is into the anterior Henry approach. And all you have to do with your incision is extend it further distally. I usually will, your deltopectoral starts here, I extend it all the way down just in the center of the humerus. Really easy to make your skin incision. Your dissection then continues. You've already got your pectoralis, and really the key is when you're doing your dissection, you're gonna dissect over pectoralis, and then you're going to come onto the biceps. When you hit your biceps fascia, you incise it. Your biceps muscle is sitting right there. Retract your biceps medially. That's the key. Always retract biceps medially. And then you've got your brachialis underneath, and that's basically a muscular split right down the middle of the brachialis. There's going to be branches from the musculocutaneous nerve as well as the radial nerve to innervate the brachialis. So when you're doing this, just be careful. Usually my way of doing it is I actually just don't take a cautery and bovie bluntly right down it. I take a Metzenbaum, and so I spread in the middle of it. I see there's going to be vessels that are crossing, clamp them, ligate them, and then kind of just try to avoid either a lot of bleeding or getting close to one of the major branches that comes from the radial nerve or the musculocutaneous nerve. In general, if you're doing this for obviously a fracture, you don't need to do anything to the pectoralis. But if you're doing it for arthroplasty, almost all the time you're doing it for revision, you need to take the pec down. So don't be afraid. Cauterize the pec directly off the humerus, release the entire pectoralis off, then you've got the entire exposure of the front of the humerus to work, and then at the end of the case, just use suture material to repair your pectoralis back. You don't necessarily need to drill tunnels or anchors or whatnot in the setting of an arthroplasty. You can basically just repair the pectoralis soft tissue to soft tissue, and it will heal. And that's pretty much it. So the last little point about this radial nerve, what do I do with an anterior approach, Henry approach? I almost never expose it, never. There are people that always expose it, place a loop around it. George always does it. Joaquin always does it. I'm sure Andy always does it as a hand surgeon. He always does it. And my opinion is that this nerve, if you stay on bone, the likelihood that you're going to injure it is exceptionally rare. And even passing cerclages, et cetera, around the humerus, The key is staying on bone, honestly, when you're actually doing that. So where are the safe intervals for, the humerus? The first safe interval is the latissimus. The entire latissimus insertion, there is nothing neurovascular there. The axillary nerve is proximal. The radial nerve at the latissimus insertion, and where do you think the radial nerve is in relationship to the latissimus, the portion of the humerus? Where's the radial nerve? No. So if you've got the humeral shaft here, you've got the latissimus coming in here. Here's the plexus up here. All the nerves are coming here. Where's the radial nerve, you think, in relationship to that? Nope. We got a couple more choices.
Proximal.
Kind of. Medial.
Medial.
So it hasn't gone behind the actual humerus at this point. So if you look at the insertion of the latissimus and you track that out medially, it's about 2.5 centimeters medially. So it hasn't actually gone posteriorly. So this whole zone right here is safe as can be. So you can put whatever you want there and it's totally safe. The next place, landmark, is where the radial nerve is when it's directly posterior to the humerus. And that location is at the deltoid insertion. So as the deltoid comes to insert here, the location of the nerve is exactly here. So that's why if you're actually using an external fixator, if you're using some type of fixation for the lateral margin of the humerus, screws that are coming from lateral to medial from a plate or from a nail, one of the most safest place to put an external fixator pin is directly in the deltoid tuberosity, because there is no chance that you're going to actually get the radial nerve because it's directly posterior to the humerus at that point. And then obviously you guys know the relationship from the lateral epicondyle. It's usually about 11 centimeters proximal that it's going to exit. So for me, locations of work, I'll be here. This is where I'm going to be putting cerclages or whatnot. I'm going to try to 100% avoid doing anything right here at the level of the deltoid insertion. And it doesn't make sense anyways, because if you're going to put something there, then you got to take the deltoid down, which doesn't make any sense. And then the other location that's actually pretty safe is right here, because it hasn't actually come around the bend and actually it hasn't come anteriorly. If you're going to be doing stuff here, you're splitting brachialis right here. And honestly, when you're doing this, you can get completely circumferential. You can get a Chandler retractor on medially, laterally. So you're staring at the entire bone from both sides. If you do that, the chance that you're going to injure the nerve is pretty low. So the only time where injuring the nerve becomes probably a reality for you, for me, is when there's prior fixation. And I've been stupid in this case in the past, is that if someone has placed a plate that's a direct lateral plate, and you go in there to do an arthroplasty, trying to take out the entire plate, that you've got a pretty high chance of actually disturbing the nerve, because you're peeling the nerve off of prior hardware, and this nerve won't take a joke with when you actually do that. So my recommendation with that is you just leave it. So take your proximal screws out, leave your plate, and put your arthroplasty in, and don't even think about removing it. And so whatever it's worth, I've been there and made the mistake in the past, so you don't need to do it. Do you expose the nerve distally?
Yeah. If I'm doing something distally, not putting cable around or
Yeah.
plating or whatever.
Yeah.
I'll just find in the interval. I don't put a loop around it.
Sure.
I just find it and then track it until it goes close to the humerus and where it is.
Yeah.
I do that like right away.
Yeah.
First step I do.
Yeah. Peter?
It depends on distal. It's not common back and forth like that.
Yeah.
If I'm just placing cerclage, like, and I don't have to go distal, I will not find it. I will just stay on bone with
Yep.
ski, and I've not had real nerve puzzle.
Yeah. Anyways, it's kind of, most of the times that you're distal like that, the times that you're doing it is, okay, you've got a periprosthetic fracture in the middle, and that's when you're going to actually be working. The reality is you can shotgun the distal portion of the humerus oftentimes, because it's a periprosthetic fracture. And when you're doing that, you can strip soft tissue from proximal to distal. And when you're doing that, you can put your cerclages from proximal to distal. And then you know that you're safe, that you're directly on bone. The other time is if you're doing a window. And so if you're doing a long window, the reality is putting cerclages, you can do that. How I'll do my windows oftentimes is that I will I won't use cerclages. We'll repair it just with suture from the interwindow. The last time is if you're going to use the plate, bone plate. And so if you're trying to support or give back more bone to the humerus, that's the only time where you're probably at risk for actually hurting the nerve, because the humerus is still a tube, a single tube, and you're putting a bone plate on the front, and then you got to kind of make sure that you're okay, or you dissect it out. No, it's not bad to dissect it out. It's just that I haven't found the need to actually do that. That's pretty much it. Any questions? All right.
I have a quick question.
Yeah.
So, I guess you and Dr. Joyce, we are